So there's some very interesting questions. I'll start off with what is a logical first question that didn't come to me first. Can you please explain the 5 stages of Parkinson's disease? Well, the 5 stages are completely arbitrary in a sense, but this is what it is. It's called the Hoehn-Yahr scale. These were well-known neurologists and pioneers in the study of Parkinson's disease. And they devised a scale of progression. The first stage of the illness is the presence of one-sided symptoms. And that's, if someone comes in and both sides are involved, it's either in a more advanced stage or they don't have Parkinson's disease. If they never began with symptoms on one side, it's unlikely to be Parkinson's disease. So the first stage, it could be either right or left side, either slowness of movement or tremor or rigidity, only on one side of the body. That's stage 1 on the Hoehn-Yahr scale. And many of you who have Parkinson's disease will recognize it began in either the right side or the left side. Those that have atypical Parkinsonism will tell you what began with my gait, where I couldn't, my gait was small, but my arms weren't affected. Well, that's lower body Parkinsonism. It doesn't follow the normal staging. Only Parkinson's disease follows this stage. What is stage 2? When both sides of the body are involved. However, one side will always be more involved than the other. So stage 2 of Parkinson's disease in the Hoehn-Yahr rating scale is bilateral symptoms of either slowness, rigidity, or tremor, with one side more than the other. It's never symmetric. Third stage. Finally, the effect on gait and balance becomes evident. In the third stage, people are beginning to feel unsteady on their feet, and they can tend to lose their balance. And they tend to recover from their balance, though. That's stage 3, when people are beginning to lose their, quote, postural reflexes. And that's basically capacity of the body to recover its position in space when it's suddenly shifted off center of gravity. We do this all the time as we've grown up. But with Parkinson's disease stage 3, the ability to recover from a trip on the sidewalk is very limited, and one can fall. So when people begin to have problems with falling in stage 3, the first 2 stages, there should be no increased frequency of falls or tendency to fall. Stage 4 is the situation when people have fallen, and they fall easily, but they can still ambulate. They can ambulate with a walker, with holding the arm of their spouse or caregiver, or with a cane. But they're at high risk for falls, and they may still fall despite the use of a walker. If they're falling despite the use of a walker, and that happens, that's stage 5. And people really cannot ambulate independently, even with a walker. And so that's considered the advanced stage of the illness, where people are mostly chair-bound, they need help for moving from the chair to the bed, they can't initiate anything on their own. So that's stage 5, and it all relates to the part of the body that's involved. Stage 1, one-sided part of the body. Stage 2, both sides. Stage 3, beginning to fall. Stage 4, falls are sufficiently frequent that you need a walker or assistance. In stage 5, even with assistance, you're still at risk for falling. The other question I had here. The follow-up to that question is, what can a Parkinson patient do to slow the progression of the disease? How can you stay on stage 1 for 20 years? Well, we've always talked about that. There are a number of things. It's called the neuroprotective strategy. And we take antioxidants, coenzyme Q10, creatine. These are agents that are currently being studied to slow progression of the disease, needs to not advance into the next stage of the illness. There's evidence that fairly high doses of coenzyme Q10 can slow the progression of the disease. But it's not a dramatic effect. And there are studies ongoing now with really high doses to see if more is better. The other approach to slowing progression is relying on exercise. And there's more and more effort in this direction. And it's simply stated is that increased perfusion of the brain with blood, in other words, increased cardiac output, cardio aerobic exercise, gradually entered and gradually advancing so that you can spend more time on that treadmill or on the elliptical or on the stationary cycle, or with brisk walking. You get your heart rate up to about 80% of the maximum for your age, and everyone has to determine what that is. That increased blood flow may have an impact in slowing progression. Certainly in animal models it does, because it results in increased fertilizer for the brain. And by fertilizer for the brain, I mean neurotrophic factors are elaborated and synthesized in greater profusion when the brain is perfused. So those are the main things for slowing progression. As well as sleeping well, eating well, having good family support, laughing 5 times a day. That's never really been studied very well. And what about green tea and PD? And that's logical. It's a different questioner. And there's a lot of, I've always known that green tea and studies that are called epidemiological studies, there's seems to be a slower or less frequency of Parkinson's disease in the population that uses a lot of green tea versus those that don't use green tea. So increased green tea consumption was reported, and I have notes here, to correlate with reduced incidence of dementia, Alzheimer's disease, and Parkinson's disease. That was reported in 2008, and that was epidemiological studies. So they look at populations, they look at the general population, the frequency of Alzheimer's, and within that group, how many of them drank green tea versus the age-matched control population, how many drank tea. And that's how they do those studies. So it's correlative. It's no cause and effect. It doesn't mean that if you drink green tea, you won't develop these illnesses. It's an association. Just like an umbrella and rain are very strongly correlated, right? But the umbrella doesn't cause the rain. So this is what you have to remember. Correlations do not imply cause and effect. It's a very important rule. It's so easy to cite this data. But if you're a big coffee drinker, you're less likely to have Parkinson's disease. But there's no cause and effect there. It's a correlation. Green tea, though, is quite interesting because it has valuable antioxidants of a class called polyphenols. And we know that the polyphenols are protective against a whole range of age-related disorders. There's a tremendous scientific interest in this green tea, and there's an active compound, which is a polyphenol. It's called epigallocatectin, and even I, who's good with languages, can barely pronounce it. It's a neuroprotectant in Parkinson's disease models, and it's extremely effective at getting into the brain, so you can take it orally. So they've isolated an active agent from green tea that will eventually, hopefully, be available for us to study. Israeli researchers showed they could prevent cellular changes associated with Parkinson's by pre-treating mice with either green tea extracts or this compound called epigallocatechin, C-A-T-E-C, catechin. I don't know how to pronounce it, I have to look it up. Anyway, this research has been repeated and other laboratories have confirmed it. And then in cell cultures that contain neurons that do develop the disease in artificial model, they showed that the green tea extracts protected against activation of the inflammatory processes that lead to cell death. So it has also very potent anti-inflammatory agents. Theoretically, it would be good for arthritis, which is another comorbid disorder with Parkinson's disease. It's very rare that I see a Parkinson patient who also doesn't have joint issues, pain issues in the joints, the knees, the hips, the hands. The another thing that I just learned about is that this green tea extract inhibits dopamine degrading enzyme, COMT, so it's a lot like Comtan. You know, many of you take Comtan, known as entacapone, with the Stalevo, or I added on to levodopa to decrease the metabolism of levodopa. It turns out that this has some COMT inhibitory effect. So it could kind of work well with levodopa. But usually, it's just as we use multiple combinations of prescription drugs to capitalize on their synergistic effects, we can capitalize on green tea's neuroprotective effects while at the same time alleviating some symptoms. Because it's one thing to slow the progression of the disease, but it won't produce any change in symptoms. But in this drug, it may slow progression by its neuroprotective capacity, but because it potentiates levodopa, might give you a little bit added symptomatic relief. So that's a kind of an interesting, and the article was about its neuroprotective, anti-inflammatory, and anti-COMT actions. So I find that interesting. Next question: what medicine can be used to help slow down memory loss? If we really had a good medicine for that, it would be bigger seller than Viagra. We'd have to do the study. Which would you rather lose, your erectile capacity or your memory? You lose your memory. I don't know, that's very delicate.
Could be harsh.
Yeah. So to decrease memory loss, well, the first agents that were developed for memory loss were in the context of the dementia of Alzheimer's disease, where short-term memory is the number one issue. The ability to retain in your memory what happened just an hour ago, 2 hours ago, the ability to retain episodic events and to recall them. That is one of the things that happens in Alzheimer's. In Parkinson's disease, we don't usually have a problem with short-term memory until maybe really advanced stages you might develop that. And there's a certain overlap with Alzheimer's in some cases of Parkinson's disease dementia. But in Parkinson's disease, the cognitive decline has more to do with planning ahead a sequence of events, like what we call executive function, multitasking, following through, being able to deal with several fires at the same time, getting on the phone, getting on the conversation with your daughter-in-law, another phone rings, you say, just a moment, honey, and you get up, and it's your husband talking about this other issue. And you can switch immediately one to the other. That means you have good executive function, good frontal lobe capacity. But that becomes a problem in Parkinson's disease. So there's nothing that we know of that improves executive function, but there are medical agents, drugs that have been shown to some degree to improve short-term memory. And those are called, a class called cholinesterase inhibitors, like Aricept. And Aricept is often prescribed for Alzheimer's disease. More and more I see my patients with Parkinson's disease also on Aricept. In some patients, there is some report that it helps. And I think in those patients, they probably have a condition similar to Alzheimer's as well as PD. But in general, Aricept is not very effective in improving memory in Parkinson's disease because there isn't much of a memory problem. If there is a memory problem, then maybe it's worth using Aricept in Parkinson's. So that's one of the drugs. And there's various forms of it now. The other drug that's newer that I like, that I use for Parkinson's disease, because not only may it enhance memory, short-term memory, but it is neuroprotective, and that's called Namenda. And Namenda has an interesting pedigree in terms of how it was derived from other drugs. It's a cousin of amantadine. In fact, Namenda, the generic name is called memantine, like memantadine. And amantadine, many of you know as Symmetrel, and it's a drug that we use to treat early symptoms of Parkinson's disease, or later on to add on when a person develops levodopa-induced dyskinesia. So we use amantadine a lot. It was actually an antiviral agent, an anti-influenza A agent in the 60s, and it was serendipitously found to improve Parkinsonism. So we use it in our tool chest for treating Parkinson's disease. So when memantadine came in, I understood it was going to be another amantadine. And it was something that I I said, well, you know, if it's better than amantadine, great. And it never came out as an anti-PD drug. And it came out as an Alzheimer's drug because they took it to some researchers who were studying Alzheimer's disease, and they found that it improved short-term memory in patients with Alzheimer's disease. And we knew that amantadine and memantadine are anti-glutamate agents, and because of that, glutamate is an amino acid, excitatory amino acid that's involved in driving cell death. So if you have an anti-glutamate drug, it may slow progression of disease. So that's why I think Namenda is a good drug for Parkinson's disease. If there's a problem with memory, and it has an added hopeful benefit that it may slow progression. So those are the two agents that I recommend. And the other agent that will improve memory, guess what? Exercise, absolutely. And that's a big program going on in Alzheimer's disease with very measured types of exercise. Let me go on to my next one. What medicines can be used for depression with Parkinson's? Well, every antidepressant known to man has been used in Parkinson's disease, and we have so many antidepressants. The first antidepressants that were developed, interestingly enough, were MAO inhibitors. But we didn't know much about monoamine oxidase when it was first used. It was actually isoniazid, was developed as an anti-tuberculosis drug. And people used to be in TB sanitariums, and they did an experimental trial of a new anti-tuberculous drug. And an interesting phenomenon occurred after several months of patients being on this drug. They were dancing and singing in the halls. They were tremendously elevated in mood. And they realized that this anti-tuberculous drug had pretty significant antidepressant effects. And from that drug came a whole host of MAO inhibitors that were antidepressants. One of the MAO inhibitors turns out to be Deprenyl, but it's a very specific, and Deprenyl later became to be used for slowing progression of disease, but it's not clear if it does that. But so the first antidepressants in the 50s were like MAO inhibitors, but soon after there came a class of drugs called tricyclic antidepressants. The most commonly known, maybe many of you know it, is called amitriptyline or Elavil. And that, what it does is potentiate the actions of norepinephrine, serotonin, and dopamine. All it's a tricyclic, and I think of it acting all three neurotransmitter systems. And it has an effect on elevating mood, an antidepressant, but also it's kind of useful for Parkinson's disease. There's variations of that, many variations. There's nortriptyline, there's doxepin. They're all basically tricyclic antidepressants. And then the newest generation are the serotonin uptake inhibitors. Serotonin seems to be the key neurotransmitter that is real low in depression, whether it's in Parkinson's disease or depression in other conditions. And so agents that increase the levels of serotonin at the synapse are antidepressants. And the first of the class was Prozac. And now there's a whole host, there's at least 12 different SSRIs or these kinds of drugs. And they all are useful for depression and Parkinson's disease. The choice that I use depends on how bad the sleep problem is. If people are having a lot of sleep problems and depression, I'll use an antidepressant that makes people very sleepy. It tends to be doxepin or nortriptyline or amitriptyline or trazodone. But if they're not having a problem with sleep, I give them a daytime antidepressant, which is an SSRI. It could be, you know, Prozac or Paxil, Celexa, those kinds of drugs. And they are effective. Is MSA a kind of Parkinsonism? No, it's another one of those secret surveillance societies. No, it's actually multiple system atrophy, not the MSA, NSR, NSA. We have too many alphabet names. But anyway, MSA stands for multiple system atrophy. And that really refers to a disorder in which there's a problem with dopamine That's that's one of the systems, the nigrostrial dopamine system. And so there is some elements of Parkinsonism, probably slowness of movement, rigidity, maybe not tremor, but sometimes tremor. But they have other neurological systems involved. In some forms of the illness, the autonomic nervous system is markedly involved, and that form of MSA is called MSA autonomic. Another name is Shy-Drager syndrome. In those patients, they have slowness of movement, rigidity, but when they get up, they almost pass out because they can't maintain blood pressure. Pressure just plummets to the ground. That's MSA autonomic subtype. MSA that has a lot of cerebellar dislocation, it's called olivopontocerebellar atrophy, is another name for MSA of the C, cerebellar type. The cerebellum are these lobes in the back of the brain that are responsible for timing and rhythm. And anyone who has a lesion in the cerebellum, when they reach for something, their arms all over the place and they have this kind of oscillation. And if they have a midline cerebellum, they're walking like this, and they tend to fall. So cerebellum is involved in balance and timing. When MSA cerebellar type, also known as OPCA, also known as olivopontocerebellar atrophy, and that name refers to the different parts of the brainstem that are involved. There's a part of the brain called the olive. There's a pons, the bridge. There's the cerebellum, pontocerebellar atrophy, and they shrink. And that is a form of Parkinsonism that has a lot of dysmetria. So when they reach out, they have very marked action tremors. Unlike Parkinson's patients that have a rest tremor, they reach out, it stops, and then they may develop a fine postural tremor. But they don't have this kind of tremor. If you see a Parkinson patient that's slow and rigid and has this, they also develop a lot of other stuff like peripheral neuropathy, spasticity. And there's another form that is cholesteroidal nigral degeneration, where it involves not just slowness and rigidity. It doesn't get better with dopamine. Many of these MSAs don't get better to a great degree with dopamine replacement. To the extent that their problem is due to dopamine deficiency, that's the most that you'll see improve. But since other systems are non-dopaminergic, you may not see much improvement with just dopamine replacement. There's a number of other variants. The one that is kind of a striking one, it's another one that's a mouthful. But if you know the anatomy, then you can say it. So this one is called basal ganglionic degeneration. And that involves is the cerebral cortex, which is the most recent development of evolution. The higher cortical cortex is where all associations and processing of consciousness and what we consider to be human characteristics of thinking take place in the cerebral cortex. And that is involved. And the basal ganglia, which includes many structures, including the nigrostriatal system, they have a dementia that's very pronounced. An alien limb syndrome, where you show a person the arm and ask them whose arm was it, they won't know if it's yours or theirs. And they have problems with gaze, voluntary gaze. And that's a difficult illness. It's another multiple system atrophy. Another atypical Parkinsonism that's not considered really MSA, it's just PSP, where they have Parkinsonism, slowness of movement, rigidity, but they can't voluntarily gaze up or down. But they don't have that dementia of the cortical basal ganglionic degeneration. Just to show you how complicated this all is, let me just show you how simple that we think, rather. It's very complicated because so many other parts of the brain can be involved, but yet they're given a diagnosis of Parkinson's disease because the doctor sees the slow movement, very slow, very small amplitude movements, gait that's very slow, but there's a whole bunch of other signs that they're not paying too much attention to that would let you know it's a multiple system atrophy. So you treat it like Parkinson's disease and a little bit of better, quicker movement, but it won't improve the lightheadedness when they stand up, right? And worsens it. It won't improve the action tremors. It won't improve the spasticity that decreases dexterity. So this is the problem with the atypical Parkinsonisms. Generally, out of 100 cases of Parkinson's syndrome, in other words, they have slowness of movement, rigidity, plus or minus tremor, 80% are of unknown cause and do well with dopamine replacement. 20% are the atypicals or multiple system atrophies. So the likelihood of someone having the atypical is in the minority, but I see a lot of them because there's the people with run-of-the-mill PD can be taken care of by their family doctor for the first 5 years. It's only when there are more difficult, complex cases where Sidmed's no longer working, the family doctor ditches them, or the family neurologist says, well, I don't know what to do. So they come to see a tertiary center like us, and we know a little better what to do, but not that great, so we do the best we can. There's a lot of research in these other forms. So we're getting there. I think I'll answer all the questions. I was thinking I wouldn't. This is always an interesting. Is Parkinson's disease an equal opportunity employer? Actually, the question is, does Parkinson's affect more males than females? Well, first of all, it's not racist because now we know that African Americans have just as high a prevalence of Parkinson's disease as European descended Americans. It used to be believed that we didn't see that many people in our academic centers who were African American. It's because of access to health care. These people didn't see doctors. And when they had their problem, their families, oh, they're just old. You know, don't worry about it. So, but no, when they did a door-to-door survey in Mississippi, in African American neighborhoods, they found very high frequencies of Parkinson's disease, and people didn't even know they had it. So it doesn't favor a race. White, black, yellow. Chinese are loaded with Parkinson's disease in Asia, India. So it's universal in terms of racial predilection. In terms of men, women, interestingly, it affects men a little bit more. Just shows that men are a little weaker, you know. But it's not that much more. It's like 53% to 47%. Just a slight percentage more. And women live longer than men. So, but this is age-corrected frequency. So it has not to do with the fact that men are dying earlier, so but basically, it has nothing to do with age. It has more to do with the fact that men are more likely, by a very small percentage, to develop Parkinson's disease. Here's another question. Have any causes been found to cause for developing Parkinson's? What are the causes of Parkinson's disease? Well, by definition, Parkinson's disease has no known cause. We call it idiopathic. So 80% of the cases that we see, we can't pinpoint a cause. We call it idiopathic. No known cause. That's the term in medicine. When I explain to medical students what idiopathic means, the doctor's an idiot and the patient's pathetic. We don't know. You know. Then they'll always remember, oh yeah, it's one of these idiopathic disorders. You know. It turns out many disorders are of that sort. But 80% of the cases of Parkinson's syndrome are idiopathic. About 4% have a genetic component, and we've been able to identify genes involved, especially the Parkin gene, which is a young onset Parkinson's disease. So we can do a genetic test. That's a very small percentage of people. Environmental toxicants and poisons. We definitely know that MPTP, which is not frequently found in the environment, but just an accident of underground drug synthesis, resulted in a cluster of young people, about 500 young people from the San Francisco Bay Area, who were IV drug abusers. It's basically all of the IV, a large contingent of the IV drug abusing population in the mid-'80s in San Francisco developed Parkinson's disease. And they were in their 20s and 30s. And Langston was able to get a sample of the drugs that they were injecting, and he identified a compound that was similar to what they thought they were injecting, which is Demerol, synthetic Demerol, which many of you know is meperidine. It's a synthetic opiate drug for pain. And they were selling it in San Francisco as China White, a new kind of heroin. And when they injected this after multiple times, this MPTP, which is a contaminant of this underground laboratory synthesis of Demerol, zoomed in, got into the brain, and destroyed dopaminergic neurons. So they developed a very quick onset Parkinson's disease. And they responded dramatically to levodopa, but within 6 months to a year, they had levodopa-induced dyskinesias, which is interesting. And so they would have massive wipeout of dopaminergic neurons that usually takes a decade for a human, an adult onset idiopathic. But in drug-induced or toxicant-induced Parkinson's disease, and I shouldn't call it Parkinson's disease, but drug-induced Parkinsonism, it was pretty quickly. And it continued to progress, which was interesting. You'd think, well, they stopped using the drug, maybe they could stop it cold. But the illness, once you have a certain population of neurons that are dying, seems to go forward and continue to worsen. So that's an example. Other compounds, other agents that have been, that's a cause and effect, there's no doubt. Because we can produce Parkinson's disease in a mouse or a monkey by giving them MPTP, and that's one of the positive things that happened by discovery of MPTP. We began to have animal models for how the death of neurons occurs. And from studying how MPTP works, we're able to learn that MPTP is converted into MPP, which looks like dopamine, and that's why it gets into dopamine neurons. And once it's in dopaminergic neurons, it poisons mitochondria. Having learned that from studying the animals, we began to look at mitochondrial function in Parkinson's disease around 1988. And sure enough, there's a mitochondrial deficit in Parkinson's disease that looks a lot like they had been exposed to MPP. And so that's why we developed mitochondrial cocktails like coenzyme Q10 and creatine, because we know that the mitochondria, which is the furnace of each cell where energy is produced, is burning fuel improperly and producing a lot of free radicals. So that came from studying an environmental toxicant. Now, interestingly enough, the structure of MPTP, I got involved in looking for hundreds of compounds that are commonly found in the environment that have similar structure. So this is such a simple chemical structure that I'm going to test all of these environmental agents and I'm going to find the cause of Parkinson's disease, right? I figured that the people that have Parkinson's disease, probably it's going to be environmental. Let's identify what the agent is. It's very exciting times. I spent 15 years studying the neurotoxicology of dopaminergic neurons, and I did find a few that killed dopaminergic neurons in cell culture in mice, but they didn't explain it in humans. One is called dieldrin, which is a banned pesticide. It also poisoned mitochondria. It produced Parkinsonism in mice, and it's found in humans, even though it's been banned since 1970, along with DDT and other pesticides of that sort. It's found in the body because it's hard to eliminate from our biosphere. It stays in fat tissue. So I got a call from a cotton farmer who had read about this. I said, I need to find individuals that have high levels of dieldrin in their blood and see if they have a higher frequency in that population. So I got a call from a doctor from a town in Clarksville, Mississippi, and he said, well, in this town, everyone's involved in the cotton business, cotton farming, and there's a tremendous frequency of Parkinson's disease here. We've always thought it's because of the well water, because we knew that drinking well water. So we arranged for about 30 blood samples from the farmers who had Parkinson's disease to be sent to us at the University of Miami, and 30 samples from people that had were exposed to the same conditions of the same age and sex, but didn't have Parkinson's disease. What did we find? Everyone had sky-high levels of dieldrin, but the people that didn't have Parkinson's disease had even higher levels, perhaps didn't reach, and so just having high levels of this pesticide didn't produce the disease in everyone. So that brings in the second component to all diseases. The genetic predisposition, how we handle environmental toxicants, is the key. And so probably individuals who are exposed to high levels of these potentially very neurotoxic compounds that can cause Parkinson's disease probably have the ability to metabolize these toxins better than others. And that's where it stands. The interaction between environmental exposures and genetic endowment is the answer. As it is, and it's a complicated issue, just like studying intelligence. Clearly, you inherit a lot of genes that make you more likely to succeed. in school, for example, in that kind of learning environment. Those genes may not make you a better farmer, though. It may not make you a better athlete. But there are genes that we know that some people have tremendous memories, photographic memories. It's a genetic thing. And those people will do well in academics. But we know that people who may not have those genes, who are raised in a very enriched environment, a loving, enriched environment with great educational opportunities, they can become academics and physicians and rocket scientists and theoretical physicists. So clearly the environment is key. Genetic factors are key, and if you're blessed both ways, you come from very good genetic background that has kind of selected for intelligence, quote unquote. Intelligence, by the way, is a strange word, but when I refer to intelligence, the ability to learn new things, to adapt to novel challenges, that's really intelligence is all about. And so how one's final IQ turns out, intelligence quotient, which is also a problematic thing. You can't really truly measure intelligence. What you measure is how well people can take tests and how well it conforms to the average population. But I got off on a tangent, I'm sorry. But you know, it's an important tangent because in health and disease, the relationship between your genetic endowment and the environment is what determines who you are. You know, even people who are genetically very small, if they're raised in certain environments, they get a lot bigger than the family. You know, that happens. And so, in everything that we talk about, health and disease, the genetic aspect is very critical, but don't forget the environmental role, especially small molecules that are all around us in the earth, in the air. I'll go into the next question. We're almost done. And you know, it wasn't too bad, just one tangent. Okay. This is you know me. You miss them? Why? I'll give you another one. Well, this one is a good one. This was a question that was sent in. I don't know if the person here was sent it in, but when considering, this is very specific, but it has a general question. When considering bladder tie-up procedures and hysterectomies to relieve intolerable ongoing stress incontinence after failed pessary use, what consideration should be given to undergoing surgery with general anesthesia, especially in regard to the anesthetic's effect on a 77-year-old female with Parkinson's disease and Lewy-body disease on carbidopa-levodopa, 2,500 every 3.5 hours while awake, and Exelon patch, Exelon's another memory enhancer, every 24 hours. So this person is 77 years old, has PD, but LBD, Lewy body disease. I mean, she has dementia. And people who have dementia that undergo general anesthesia are going to have a worsening of their dementia for a while. And they're going to be difficult patients because they'll be delirious, confused, disoriented, may try to run away from the hospital, be very frightened. So it's a very risky business to do general anesthesia in someone with dementia. It can be done, but they need a lot more care. And the surgeons and the physician staff have to be aware that this person is likely to develop confusion, post-op confusions, disorientation, hallucinations, fear of hallucinations. So one of the things I would recommend in this case is that right after the surgery is done, and to make sure that she sleeps at least 6 hours, is that a drug like quetiapine be used. It's one that many of my patients know I use to promote sleep and to protect against drug-induced hallucinations and psychosis. It's the only neuroleptic besides Clozaril, the only tranquilizer that can be used that won't worsen Parkinson's. So that's what I'd recommend for this patient. And I always say, really think about how important this surgery is. If you can avoid it and you can deal with the incontinence, great. But on the other hand, the incontinence is very unpleasant, very difficult for everyone. So it's a risk you take that you may have a worsening of your dementia, a delirious state with agitation and confusion. The other thing is, before any general anesthesia, for any procedure regarding what kind of Parkinson's disease you have, if you're on an MAO inhibitor, you have to stop it. So rasagiline or selegiline. Rasagiline is Azilect, yeah. Azilect or Depronil. That should be stopped for 2 weeks. because it would prolong the effects of anesthesia. The MAO kind of is important to be active, and MAO inhibitors block MAO. Anyway, so that should be stopped. And then all medicines are given until midnight. So all the anti-Parkinson medicines are given, and then the next morning, from midnight on, nothing by mouth. Anesthesiologists will come in early in the morning and put you into a restful, peaceful place so that the surgery can be done. As you recover from that, if you have dementia, you're going to be really confused. It's already confusing to recover from anesthesia to begin with. So that's the main thing. I think I have one more.
Does exercise help before surgery?
I wouldn't stop exercise. If you're doing exercise regularly, I would do it till before surgery. Yeah. Yeah, but I think I've covered it. I've covered all the questions. I'm so happy, and I can go and eat lunch.
Thank you. Thank you. Good. We'll do that in the future.